with Dr. Kawita Bapat, a platform for the conversation, insights, and the knowledge sharing work messages. We have a crisp knowledge about the various subjects through the conversation with leaders and experts with their fields. Our goal is to provide a practicing OBGYN to access the valuable information, knowledge that can help them to grow and personally and professionally. Today, I'm really very happy that we are having an extraordinary person today. That's a Dr.V. Paily. Is an exceptional senior, is a person which is a senior consultant and head of the obstetrics and gynae department, whose achievement and expertise make him an invaluable asset to the medical field. With extensive qualification, including MBBS from Kottayam Medical College, MD from Calicut Medical College, and a prestigious MRCOG, FRCOG certification from the Royal Colleges, UK. Dr. Paily has undergone rigorous training and education to provide the highest standard of care to the patients. Throughout his illustrious career, Dr. Paily has accumulated a remarkable breadth of experience, holding positions at renowned institutions such as Mother Hospital, Thrissur, Raji Nursing Home, Thrissur, Jubilee Mission Medical College, and Government Medical College, Thrissur. His tenure as a consultant and head of the department at Daman Maternity Hospital in Saudi Arabia further demonstrates his global impact on the field of obstetrics and gynae. Dr. Paily's expertise encompasses the wide range of specialties with a particularly focus on urogynae, high-risk obstetrics, endoscopy, and infertility. The diverse skill set enables him to address complex cases and provide a comprehensive care to his patients, ensuring that well-being throughout their reproductive journey. His dedication for advancing in the field through his membership certification, including his affiliation with the Federation of Obstetrics Gynecology and his role as a past president of Kerala Federation of OBGYN, that is KFOG. As a state coordinator of various initiatives, this is a really very, very important and most impressive part of what I feel about his CV is, he has done a confidential review of the maternal deaths, emergency obstetric care, life support, and a quality standards of the reducing maternal mortality rates in Kerala. And we all congratulate him that he is one of the key person or the key role person into the reducing the maternal mortality rate in Kerala. Though it's reached up to 2 digits, and I'm sure with all the efforts of the Kerala and everything, they will reach to the 1 digit soon. Dr. Paily's contribution extends beyond his clinical practice. A significant contribution in the field of his publication. He was an editor, Why Mothers Die, Kerala Obstetric Gynecology Management Protocol, as well as authoring the chapters of numerous books, articles, and national and international journals. He has shared his knowledge and insights with the medical community and understanding the development of obstetric and gynae care. Dr. Paily's wealth of knowledge, extensive experience, unwavering dedication of the improvement of the maternal health care make him highly esteemed and a respected figure into the OBGYN circle. His contributions have undoubtedly impacted the lives of countless individuals, and committed excellence serve as inspiration to the aspiring medical professionals worldwide. Sir, I am really proud that this program I have arranged and you have accepted my invitation. So welcome, Dr. Paily, sir. And we are going to have a simple conversation today is regarding the innovations which you have done and how it has been done is like this. So just a brief, anything which you want to give a opening remark, and then we can start our conversations.
Thank you, Kawita. Thank you for this opportunity for this tea time chat, and very innovative, I should say. I know that you have become very popular because of this, and you have brought out people who can give knowledge, experience, as well as take home points in your this chat program.
Yes, sir.
And when you say that innovations in obstetrics and gynecology, particularly in obstetrics, there's an area of great interest to me, and spanning over almost 6 decades, my practice in obstetrics and gynecology, and there have been occasions where we always felt the need for new developments to make our practice easier and safer for the women that we care for. And all the innovations that I have been instrumental came out because of that.
Correct.
And thank you for this opportunity to share them with you and your audience.
Thank you so much, sir, that you have that the idea is that they should have some crisp and real good take work messages which they can use for the betterment for our females. So can we start with the things? Can you tell about some important key innovations which you have introduced into the field of OBGYN? Because if I'll enumerate the list, I like people to be from your mouth more. Then, sir, I'm just asking, what are the innovations which you have introduced into the field of OBGYN?
Certainly, thank you. The first thing actually I started working on was the obstetric forceps. As all of you know, this is a dying art, as we usually say, but I feel it should not be allowed to die. If at all you have vaginal delivery, then there is a need to help out a baby in distress, or maybe in mother in distress. And for that obstetric forceps, which had been there for over 4 centuries, I don't think we should abandon it. Even though in many places they have totally abandoned it, I think that is a disservice to the profession. The reason for this abandoning the obstetric forceps was, of course, the complications that come out. And a major reason for the complications was the instrument itself. The obstetric forceps that we inherited, forget about the time of Chamberlain, but the ones that are all your generation or the generation before that, all the medical colleges have are the forceps that came from the West. For example, the Sims, Mill-Murray forceps, the axis traction forceps. All these things are really huge instruments. And for our Indian women, they are really huge, and that causes complications. And because of the complications of the mother and the baby, people abandon that. So right from the beginning, in the late 90s, I started working on it and came out with the suggestion that we should reduce the size of the forceps. Even though under magnification in the camera, it looks big, this is much less than the conventional available forceps. Because the current practice of obstetrics, we could make many changes in the forceps. First of all, we are not applying forceps at a high station anymore. So we don't need the assist traction. Second thing, we are applying the forceps with the head at the low level, so we don't need much of a pelvic curve. We have better metal now available, carbon steel. Previously, the mild steel that with which many people supplied the instrument, once you boil it for sterilization, it will change its shape. Now, this steel that is available, we can make the blades thinner. The length, we can bring it down. So in all these respects, we have reduced the size of the forceps and the potential complications coming out of it. We call it the Paily forceps, and it has been published already in the international journals. And there are many friends across the country who take it, even outside, who have taken it and found that it makes the procedure so much easier. The other thing is, even though you all would have heard about the rotational forceps, Keelan's forceps, the main thing about the Keelan's is it's a straight forceps. And we could not use our conventional forceps for that because of the big pelvic curve. Of course, you would have heard about this Canzoni's maneuver and all that. But this forceps with very little pelvic curve, as you can see, very little pelvic curve can be used as a rotational forceps also. The other thing that we brought about regarding the forceps was, you see, you cannot think of applying the same forceps when you have to deliver a 1,000-gram baby and a 4,000-gram baby. So we thought, especially now that we have to deliver and look after extreme preterm babies, we should have a smaller forceps. So we brought out this mini forceps. Compare it with the other ones that I showed you earlier with the regular forceps, such a small forceps. The bilateral distance of this is only 2¼ inch. A baby which is 1,000 gram or less, we have to now deliver 600 gram, 800 gram babies, either through the vagina or during a cesarean, where you need to help out that baby. Any type of ventouse is not possible because such preterm heads, if you use the ventouse, his head will be damaged. So we have developed this mini forceps and the regular forceps and published our expertise on that. We recommend it for use during vaginal delivery as well as during cesarean section. People ask, do you need a forceps during cesarean? Yes. You see, delivery of the head, whether during vaginal or cesarean section, needs to be guided. During a cesarean also, the head has to be guided. Otherwise, you may have difficulties to deliver it, valuable time is lost, and ultimately the baby is lost. So for both vaginal and cesarean, we use it. And even for the after coming head of the baby in a breech, in case you are doing it, we use the forceps. So that was my first love, and that is being still.
I'll just put a word, sir, over here. See, the person like you have designed such a nice with a function like design, such a short and a curved forceps with a solid plate design. It's really very important. It's a really versatility of you because you have to able to manage it. But the problem is safety concerns are also good. But definitely, sir, the idea of using forceps all over India, once again, they need a good training and education. I think you will agree with me. And somewhere we are lacking somewhere to tell and teach everyone. So this is a really good thing, and this type of things should again be used, what I feel. And we need to, what they say, reevaluate again and to start teaching. People doing cesarean section instead can use the Paily's forceps, what I feel, for the outlet forceps, and because it's the blade is small and everything. So then that's over to you, sir, for the second innovation which you will like to talk about.
The second thing was, as some of you at least may know, we do the audit of the maternal deaths in our state.
Yeah, absolutely.
And in early 2000, what we found was, of course, in the state, our C-section rate was going up, just like it is happening elsewhere in the world.
All over India.
And we started to get patients with placenta accreta spectrum. And when we audited in 2005, for example, we found that there are 5 maternal deaths, on the table deaths, not in the peripheral hospitals, but in the medical colleges because of placenta accreta spectrum. Medical colleges, I mean, seniors were available to conduct the process, and then still they could not save the baby or the mother because they bled to death. So we had to develop strategies to address this. Looked up the literature because this is not a problem unique to us, it is all over the world, and found that elsewhere, especially in the developed world, they were addressing this problem by mainly 2 principles. One, they decided that this is a reality and such patients should be tackled only in centers specially designated for that. For example, in the whole of UK, if you think, there are designated centers where they can admit such patients, nowhere else. In London, there are only 2 hospitals where they can admit them. And in those centers, when a case is to be done, the arrangements they do was mind-boggling. They should have at least 2 senior obstetricians, 2 senior anesthetists, vascular surgeon, hematologist, blood bank officer, urologist, oncosurgeon, all these people, and equal number of nurses. And of course, they should have the interventional radiologist to block the aorta or the common iliac artery and cell salvage system, all these things, which is impossible to think about for us. So we started working. We are going to have more and more of placenta accreta spectrum, but how are we going to tackle it? And that is why we started working on reducing bleeding during the process of surgery. And we went through a lot of trials and errors and finally came out with what we call the aorta clamp or the common iliac artery clamp. Very simple device to be used by the obstetrician with average experience. We cannot even think of a cardiovascular surgeon to come and help us because how many centers can have them? We cannot at all think about interventional radiologists because it is not possible to get our obstetric centers doing it. So we developed this clamp after a lot of design changes, finally got it patented. This is a clamp, something which looks like, say, an Alice forceps.
Yeah.
But what you see at the tip is not teeth as we have in the Alice, but a guard. It will prevent the aorta. Suppose this is the aorta and you hold it like that. While we are busy operating, this should not slip out. So that is why the guard was provided. And the recommendation is that if you have to do a surgery on such a patient, we deliver the baby and immediately go and block the vessels, the aorta or the common iliac arteries on both sides, rather than get an interventional radiologist who would put an intravascular balloon and inflate it when the baby is out, which is happening elsewhere. And in many centers, they say we will have a vascular surgeon come cross-clamp the aorta. impossible. Not only that, impossible. It is associated with a lot of complications because however experienced the person is, when you try to dissect out the aorta or the common iliac artery, the chance of damage to the neighboring vessels is more and all that. So we said we should have a device which can be used by an experienced obstetrician, say middle level obstetrician,
Right.
who is capable of doing a cesarean section. And so we decided we will have a person to employ it simply like this. You have a Babcock forceps,
Yeah.
identify the aorta, clamp it, lift it up without any dissection, without dissection for uterine access or anything. Just palpate it or see it, lift it up just above the bifurcation of the aorta into two, and then bring this clamp in the open position, take the full thickness of the aorta and clamp it like that.
Amazing.
So that is how, and take off the Babcock now. So this will cut off the blood supply to the pelvis. And you can dissect in a relatively bloodless field. Bladder can be separated even percreta, placenta with less likelihood of damage. Still there can be damage. But the life-saving system here is that the torrential bleeding of liters and liters of blood required can be stopped. So this was the second innovation. And what we believe is that we have probably saved the maximum mothers out of all my inventions, this is the one, because placenta accreta spectrum is on the rise.
Amazing.
So this was,
it gave the time for the surgeon to work if it is needed in the future. So the excessive bleeding being stopped, and that amazing, sir. Amazing. Yes, sir. Over to you. Yes.
Yeah. So this was the second one that actually it was work on this started again in the early 2000, 2005, 6 time. And the instrument is patented, and we have already got it published, and we have had correspondence with the international secretaries, and then made people realize that this is a more affordable step. Interventional radiology, putting in intra-aortic or common iliac artery balloon, RIBOA as they call it, is all having availability problems, cost problems, and complication problems. There have been many occasions where they had problems because of the interventional radiology access like that, to the extent of even rupture of the big vessels and displacement of plaques, and all those things problems are there. So this is the other thing which we feel very satisfied with our invention, so that we could save mothers because of that. The third one you are asking me, and again, the major problem was because we are auditing the maternal deaths in our state, we realized that it continues to be that hemorrhage is the cause of death, leading cause of death. Even in the last year that we analyzed, nearly 20% of all maternal deaths in our state are directly due to hemorrhage. And indirectly, other causes also lead to death because of hemorrhage. For example, an amniotic fluid embolism, you may get the woman heartbeat come back, but then by then DIC would have set in and she may die because of bleeding because of that. A sepsis may go in for DIC and then bleed because of bleed to death. And all these things are there. So we started working on this. Already my colleagues in the state, Dr. Samartha Ram and later Dr. Panikar, had worked on that and came out with this suggestion that if you apply suction inside the uterus, that will make the uterus contract, rigid, and the blood supply through the myometrium will stop, and then you can do it. So they developed their own types of suction cannula, and which I think most of you would have seen. But a couple of problems that we found in practice is the cannula that was developed by Samartha Ram, different varieties are there. They are all very broad with a lot of big slits on the sides and all that. That is likely to damage. Second thing was, it is made of steel, of course, and reusable. But then at that particular moment when a patient is bleeding, getting this assembled and all that becomes a problem. And to some extent, the same problem was there with Dr. Panikar's cannula. So we said, we should have something which can be just open the pack and then use it like that. And so we came out with this disposable suction cannula. The suction cannula is just a plain plastic tube. Plain plastic tube with multiple holes over there, which can be introduced into the uterine cavity after holding the lip of the cervix with it, and then make the suction on, and you can see that we are watching this one, you can see
how it works.
this is getting rigid.
Hmm.
It is getting rigid because once the air sucked in from inside, similarly inside the uterus, when you put it in, then the thing is collapsed.
Hmm.
So blood supply to the uterus gets stopped and she will stop bleeding. So this is the principle, not my original idea, I admit, but we made the modification and made it simpler to apply it, disposable, and it costs only about 200 rupees, 250 rupees, or the whole set, the tubing, as well as the whole thing is disposable and costs only about 250 rupees. Our Kerala Federation is marketing it at the moment. And so the idea is that suction as a device is essential to stop the bleeding. It can be doable, simple, at the same time, without waste of even minutes, we should be able to implement it. It should be available in all the delivery points. All that it requires is a suction device. And of course, Dr. Samartharam and Dr. Panikkar suggested that even if electricity is not available, you should be able to employ it with the pump that with which we are using vacuum extractor before. Now, every labor room, because of the vacuum extractor, may have a pumping device. So you can use that same device, connect it, and then stop the bleeding immediately. But another problem that came up was, this is useful in the upper segment bleeding. In modern obstetrics, almost 50% of the PPH is not from the upper segment, but the lower segment.
Lower segment bleeding.
So people started to use misoprostol. Lower segment is dilated, and from there bleeding occurs. Lower segment is very friable, that causes bleeding. And because of this, lower segment bleeding will not be tackled very well by the suction tip, because these holes have to be inside the upper segment. If it is low down on the cervix or vagina, even one hole below, then it will not anymore work, because the air from the vagina will be sucked in. So we thought we should have an approach to stop the bleeding, and that is how we worked on and came out with a suggestion that we use transvaginally uterine artery blocking. Transvaginal uterine artery clamp. Can you get that uterine mode, please? No, the other one. Yeah, uterine mode. So what we thought was, if only we have a clamp like this, which can be introduced into through the vagina, into the cervix one blade, and to the lateral fornix the other blade, like that. There, you know that the uterine artery is joining by the side at the level of the isthmus. So if you have a clamp which goes one blade to the uterine cavity through the cervix, the other on the side like this, imagine this frill that you are seeing is the vagina. So on the side, you go up and then clamp it like that. See, clamp it like that. You can see that the uterine artery is completely occluded. So that is how the blood supply, 85% of the blood supply to the uterus can be cut off if you apply in both sides. You don't need anesthesia for this. You don't need power for this. And you can even teach the nurses or the midwives to apply it. So that is the main thing, and that was published. And we could get the transvaginal uterine artery clamp as a way of stopping the bleeding. It will stop the upper segment and the lower segment bleeding, but specifically the lower segment bleeding. What we, after trying both, concluded was that it may be better to use both these as complementary. We can use the suction cannula and the clamp, so that blood supply to the uterus is cut off and PPH can be immediately stopped. So that is where we are at the moment, starting to put in the cannula and put the clamp, which will happen in a few minutes, rather than wait for people to assemble this, that, everything. Our flowchart now is, the moment you see excess bleeding, you alert colleagues to come and help you. The obstetrician immediately applies bimanual compression. And the moment somebody brings the cannula, even without any retraction or anything, we can introduce the cannula to the uterine cavity. And then, as I said, the clamp is available, apply the clamp also. That's all. After we started to do this, we had no occasion in the last 5 years to take a patient from the labor room to
Hmm.
the operation theater to do all our uterine artery ligation or B-Lynch or this or that. So quick, effective approach to stop the bleeding. That is our principle now for
Yes.
controlling the bleeding.
Yes.
But during a cesarean, what will you do is the other question.
Hmm.
So instead of this L-shaped clamp, during cesarean, what we thought was we will have a T-shaped clamp like this. You can see a
Yeah.
T-shaped. So now it is possible for us, if this is a cesarean and this is the wound, we can introduce one blade into the uterine cavity and the other laterally
Oh,
go
yes.
wherever is a vessel.
Yeah.
Yes, clamp.
Excellent.
Even if the bladder is there, doesn't matter because this
It's
clamp
atraumatic.
this will not crush. See,
Yeah.
I get light on my hand like this. So without dissection of the bladder, whenever you see there is welling of blood with the clamp, stop the bleeding, wipe or suck the field, clear it, and then identify the bleeder. So that is what we did for controlling the bleeding. Now, after using both these types of clamps, we found that this T-shaped clamp, we call it the T clamp because it is vertical and the T, the other are the L clamp, but both are interchangeable and we can use the T-shaped clamp also vaginally because it is slightly smaller in size,
Yeah.
easier to apply, and that is what we would recommend now for immediate control of bleeding from a atonic PPH from the upper segment or the lower segment. So this is our approach to PPH now. Don't wait for measurement of blood and then confirming that it's 500 or 1000 ml like that.
Excellent.
The moment you feel there is excess bleeding, start acting. In addition to giving the drugs, which of course we use, by the time even to give a methergin, breaking the ampule and then finding the syringe and injecting it, we can have the cannula in and then stop the bleeding.
Absolutely.
So prompt action to stop the bleeding, that's the approach to PPH now.
Correct. So amazing, amazing. You have such a motivated and pursued your career in OBGYN in such a nice way. And all this significant impact which is being given by you to the all innovations which you have made, really a big challenge. And I like the idea because of the maternal mortality review and everything. And so many, because of this is innovative ideas are really important, sir, because we need it. And most of the innovations are basically yours are evidence-based, what I feel it, because you have so much work on it also. So I think
all these are published actually.
Yeah.
The obstetric forceps has come out published in the European journal.
Yeah.
The transvaginal uterine clamp also came in the European journal. The aorta clamp has come in the International Journal of Obstetrics and Gynecology as a management of placenta, accreta spectrum, all these.
Yeah. Yes. So all specific advancement technologies, particularly they revolutionize the OBGYN practice. And really, I think your forceps, especially the aortic clamp and the modified simple plastic cannula, I think that is a really amazing transvaginal uterine artery clamp, the T clamp, the L clamp. So it's really innovative and very impressive. But as a concluding, which I feel you have done such a tremendous work, really, do you need